Yeah, good morning, everybody. It's my pleasure to introduce Jerry Estep, and normally he does the introduction, so I figured he deserves more than what we all know about him. He's a homegrown individual who's been in the Texas Medical Center. A lot of people here know him well, but I'd like to point out that Dr. Estep has been here since his graduation from fellowship, has contributed a lot to the growth of our mechanical assist device and transplant program. In fact, was probably responsible for the outburst of the volume and the outreach that all he did, and of people who know by himself for a year, after which I joined him. More than that, he's the director, medical director for the mechanical circulatory support and cardiac transplant program. Has also emerged to become a thought leader in mechanical assist support, both in the country and internationally, leading to a recent publication, and he led the group that did the roadmap study, which is a pioneering study that we're hopeful to hear about today. With his unique skill set with echocardiography, he's also co-chaired the committee that has published for the first time guidelines in echocardiography for VADS in American Society of Echocardiography. So again, a friendly mentor for a lot of people here, and a friendly boss for a lot of people here. We're delighted to let him share these insights, which are really hot off the press. Thanks, Jerry.
Arvind, thank you for that kind introduction. And it is true, on the introduction end, I would have never introduced myself as friendly. No, I appreciate your words. So let's jump right into it. I think disclosure statements are always key. It puts into perspective one's experience and how it relates to the talk at large. I serve as a consultant and have received research support from Thortec Corporation. I've had the privilege of serving as a consultant for the FDA in terms of mitigating adverse events specifically related to pump thrombosis, which has received some attention as of late. And I will briefly, towards the end of my talk, discuss investigational use of new devices that are providing new horizons, which I think will change the landscape even more than it already has, of offering device therapy to patients with advanced heart failure. So my specific aims are as highlighted here: to provide really an update on destination therapy, both in terms of benefits and risks, and importantly, in patients that are less sick, talk about predicting outcomes in those that aren't crashing and burning in the ICU on multiple drips or inotrope dependent. And I'll use the most recent observational trial, actually the first observational trial, the roadmap trial, to highlight the observations we made and how I think it's going to guide us clinically. And as I mentioned, importantly, some discussion about future devices. So at the end of the day, every Tuesday, we meet cardiology, surgeons. I'm talking here today, but really I represent the team at large, consisting of dedicated several thoracic surgeons, heart failure specialists, care coordinators, palliative care specialists, ethicists, and really our aim is to offer intervention to those whom we feel have end-stage heart failure. We're now doing up to about a little over 350 evaluations per year. For those whom we identify as having end-stage disease, we assess the projected benefits and risk of offering either transplant or LVAD, and then take that to the patient to guide informed consent. Now, up front, I think it's important to highlight that heart transplantation still remains the most effective treatment strategy when considering long-term survival. And I put for your reference the UNOS, most recent UNOS data in terms of 1, 5-year, and 10-year survival. And I'm proud and really reflective of the team at large. Our experience mirrors that, in that patients do well post-heart transplant. The unfortunate reality is there's really a limited in the number of donor organs across the country, typically in and around 2,000 to 2,200 per year. There's a burden of advanced heart failure, end-stage disease that far exceeds this donor pool. And perhaps equally important, or more importantly, For many reasons, patients are not good candidates for heart transplant. Some are absolute, as listed here under the specific column. Some are relative. Older patients with comorbidities don't do well after heart transplant. We mandate patients are 5-year free of cancer to consider transplant. And while some cancers may be a little bit more forgiving, that's a general consensus across institutions across the country. Patients that have a BMI over 35 or obesity don't do as well in terms of rehab and some morbidity after transplant. So we take that into consideration. But as mentioned in the Grand Rounds talk a few weeks ago, some patients that have heart failure developed high pulmonary pressures that are out of proportion to their left-sided filling pressures and have a transpulmonary gradient greater than 15 millimeters of mercury, suggestive of a perhaps fixed component. And taking someone like that to transplant, you run the real risk of RV failure and multi-organ failure. And then certainly patients not uncommonly have multiple comorbidities related to advanced renal insufficiency or coexisting pulmonary disease. And for these reasons, in combination with the limited donor supply, destination therapy really over the past decade has provided us an opportunity to improve survival and increase quality of life for many patients. Now, going back to the landmark trial, and this is now 14 years ago, this was the rematch trial. And it's the only randomized trial against optimal medical therapy in terms of device support. And this was in patients that were not transplant eligible. The main reasons in that study related to age, over 65. And we put that in the context of our age selection here. Renal insufficiency, insulin diabetes with end organ dysfunction, to name the most common. But for those patients that were deemed ineligible for transplant, that had LV remodeling with severe dysfunction, poor functional capacity as estimated by cardiopulmonary testing, or deemed inotrope dependent, with optimal medical management at that time did include ACE inhibition. Beta blockers were being introduced. At 1 year, survival was 25%. 2 year, just 8%. And these are the older pulsatile pumps, which have become actually historic, but there was a survival advantage at both 1 and 2 year. So we've certainly, on teaching rounds and with discussion with referring doctors, put forth that those patients with progressive heart failure, despite refractory to guideline-directed therapy, certainly for those that are inotrope dependent, we can talk about that. These patients don't do well. And in rematch, the original investigation, inotropes were reserved for those that were hypotensive, worsening end organ function, oliguric. They made an extension to improve recruitment and define inotrope dependency as failing 2 wings. But the majority of patients were the traditional need for inotrope in terms of clinical failure. And so I always keep that in mind because we can use inotrope certainly at our discretion in terms of perhaps softer indication. But even based on more contemporary data, patients that are truly needing inotropes to maintain stability, be free of overt heart failure, don't do well. So destination therapy really, based on this landmark trial, in addition to another one which I'll show you, has taken off. When I started here in 2007, really we were doing aggressive clinical research in device therapy. Our destination therapy cohort, our whole VAD cohort actually was around 12 to 14 patients. Destination therapy as a strategy was under 10, 15%. And over the past few years, really it's now over 40%. Here at our institution, it roughly equates to about 65 to 75% of all our implants, for reasons I mentioned in terms of patients not being good candidates up front in terms of listing for transplant. Now I've highlighted here really multiple clinical trials, both the randomized rematch, the HEARTMATE 2 destination therapy landmark trial published by Mark Slaughter and colleagues, and post-approval therapies, all under the umbrella of destination therapy. And as you can appreciate, with improvement in technology using these continuous flow LVADs, improvement in patient selection, improvement in management, 1 year outcome for these patients is in around 75%, with 2-year outcome just under 70%, around 68%. Now, in addition to clinical trials, we have been contributing our patient data, if you will, for all patients that receive an LVAD to INTERMACS. It, until recently, has been a mandate by the FDA and is really a collaboration between the FDA, industry, and clinicians to learn from observations as illustrated here. We certainly know that patients that we put an LVAD in to get to transplant tend to be less sick, and their 1-year survival based on more contemporary data is around 80%. Patients under the umbrella of destination therapy with more comorbidities that are excluded from transplant, their survival is a little lower, but the concept is, in my mind, clear. Currently, for those patients with the sickest of sick signals in terms of heart failure, there is a survival advantage compared to projected medical therapy. So those patients in the hospital, on the vent, or inotrope dependent. Equally important in terms of discussion with the patient and patients' families, it's not all about survival. And this is an important concept, especially as you transition to less sick patients. We use, both in terms of research and INTERMACS, the EQ5D. The patients look at this, it's from 0 to 100, and they report their overall health state, 0 being worse, 100 being best imaginable. And pre-implant, these values typically are under 40 to 50. Post-intervention, even as early as 3 months, as patients get over the early perioperative challenges, have significant improvement in their reported well-being. And this extends out to 2 years. And when you look at important metrics related to self-care and returning to usual activities, it's very reassuring that these patients are doing well. For these reasons, there's really been an explosion across the country in terms of increased utilizations and adoption of this technology. So highlighted here, this is from INTERMACS. There are now over 10,000 accrued patients, over 150 activated hospitals, and it's really based upon the landmark trials, certainly rematch in 2010, approval of the HEARTMATE 2 for destination therapy. So taking that into consideration, I've listed here the contemporary destination LVAD implantation criteria for patients that are shortness of breath, that have shortness of breath with minimal exertion or at rest, ejection fraction less than 25%, poor functional capacity, or sicker in terms of inotrope dependence or needing a balloon pump, and deemed not a transplant candidate. These are the types of patients we would consider for long-term therapy for the rest of that patient's life, understanding that we're going to try to tailor it to the specific patient, the projected benefit in terms of survival and quality of life, versus not pursuing with device therapy. I wanted to highlight the more recent study in the context of destination therapy. This was presented by Frank Pagani from Michigan at the most recent International Society of Heart and Lung Transplant in Nice in 2015. It's the first really randomized trial in a cohort of patients deemed ineligible for transplant, with a primary objective to compare safety and efficacy of the HVAD to the really only FDA-approved LVAD, the HEARTMATE 2, in patients with end-stage heart failure. The HVAD is centrifugal, meaning blood comes in, they're both rotor pumps, comes in, leaves at a right angle, and is delivered into the ascending aorta. It's adjacent to the pericardium. The HEARTMATE 2 is subdiaphragmatic, axial, blood comes in and leaves parallel to its flow in a similar fashion delivered to the ascending. They're both approved here in the United States for bridge to transplant, but based on INTERMACS and registry data and post-approval data, what we've learned in terms of destination therapy really is based on the HEARTMATE 2 experience. From this trial, I'm not going to go into the details in terms of adverse events, but non-inferiority was met. And this was not survival in and of itself, but it was survival at 2 years free from disabling stroke, and roughly 55–57% for both pumps. I think it's important to keep in mind, even in a contemporary large multi-center study, more recently published, that 75% of all these patients were sick patients. INTERMACS 1, that's crashing and burning, and we're trending to do that less in the context of less likely to be successful, and I'll discuss that. But the majority of these patients were either INTERMACS 2, failing inotropes, or dependent upon a balloon, or inotrope dependent. And really there's been a lack of data to guide us on really what are the projected benefits and risks in patients that are less sick. So if we take a step back and ask, what is the outcome data that we have regarding advanced, non-inotrope dependent ambulatory patients? And it really is derived from INTERMACS, which has been in existence as a registry since 2005. I'm going to highlight observations from MEDAMACS, which is the medical arm of INTERMACS. It's a cross-sectional observational study for patients that may become VAD potential candidates that are non-inotrope dependent. I'll highlight the post-approval HEARTMATE 2 study observations related to less sick patients. And I'm going to spend a lot of time going over the roadmap trial. Revival is an NIH-supported registry with the idea of capturing more information to understand the natural progression of patients that fall into this profile of non-inotrope dependent advanced heart failure. And I think it's important in this patient population for a number of reasons. At a program level, certainly not want to wait until patients are too sick and they're dying of a multi-organ failure and their candidacy is compromised, but not wanting to implant if patients are not sick enough. Heart transplant above and beyond the limited resource and not being available for everyone in terms of indication and exclusion, it's a scarce resource. Increased scrutiny related to cost effectiveness, and I think importantly, when designing trials, looking at endpoints. We know we have at our armamentarium heart transplant and LVAD, and I think predicting events is really most applicable when considering death, urgent heart transplant, or urgent need to LVAD as these less sick patients become more sick. And so we have learned a lot from INTERMACS, and we have learned a lot from multi-center retrospective studies. Andy Boyle and colleagues, 3 studies, showed us that in those patients that are the sickest, again, INTERMACS 1, 2, and 3, those with patients that fell into INTERMACS 1, a little over 100 patients with continuous flow LVADs, these are the patients that had the worst perioperative and long-term survival. That was compared to a cohort of patients that were not as sick or not in the hospital crashing and burning, and not inotrope dependent. So INTERMACS 4 through 7 patients, recall, INTERMACS 4, resting symptoms, 5, comfortable at rest, but symptoms with minimal activity, INTERMACS 7 being more advanced stage 3 type of patient population. So at least in terms of observations, in terms of perioperative survival, much, much less in the less sick patients. And as one would hypothesize, their post-implant length of stay significantly lower compared to those that are sicker. And this makes sense. Those patients that are the sickest in terms of cardiac cachexia, coexisting end organ dysfunction, these are the patients that have challenges after surgery. When we look at INTERMACS, as published in the 6th report, those patients that are INTERMACS 4, that's highlighted here in the black line, they have a 1-year survival that's greater than that of patients that are the sickest. So it mirrors what we've learned from smaller retrospective multi-center observations. And when you look at the most recently published study as it relates to destination therapy, this was the FDA-mandated post-approval HEARTMATE 2 study. Those patients that were INTERMACS 4 through 7 had a 1-year, 2-year survival as listed, 82, a little over 67%, compared to patients that were less sick. So on one hand, we're very optimistic that perioperative survival and how patients will do is perhaps better when they're less sick, but we want to have equipoise that it's weighing and balancing out adverse events. Highlighted here is the concept that those patients that are the sickest we know don't do as well, and there's been a transition or movement in the field where now it's under more contemporary data, under 5–10% of us implanting LVADs in patients that are in critical cardiogenic shock. If we get a call in the middle of the night or during the day and someone has a blood pressure of 70, on the vent, in renal failure, on 3 drips, we're not going directly to a permanent LVAD. That's a contraindication. These patients don't do as well. It's a whole nother grand rounds on how we treat that patient in terms of optimizing their candidacy with the use of short-term devices. We look at a lot of modeling to try to help predict perioperative risk and long-term survival. But I think the concepts, when you keep them simple, are clear. Those patients with the most overt disease and compromised nutrition, right heart failure of greater severity in the context of progressive left-sided heart failure, and end organ dysfunction begets challenges at the time of a major challenge like surgery. And we do, per protocol, a number of root cause analysis in terms of quality performance initiatives to look at challenges related to morbidity and mortality in our patient population. And it is, we always circle back to what we've known really for several years. Those patients that are the most sick, hemodynamically unstable, compromised end organ function, coagulopathic, severe right heart failure, unclear neurologic status, on the vent, these patients don't do well. We will not jump into permanent LVAD in these patients. So let's transition to MEDAMACS in terms of insights from those patients that have advanced heart failure, and I'll qualify that in terms of the MEDAMACS definition. This is pilot information that stems from the experience of 10 hospitals. The intent as listed was to assess survival function over time, quality of life, and eventual consideration of LVAD, again, in an ambulatory cohort. To get into MEDAMACS, you had to be at least age 18, shortness of breath, either at rest or with minimal to moderate exertion. Again, a reoccurring theme in terms of surrogates of LV remodeling, EF less than 25%, heart failure symptoms for at least a year, and importantly, failing guideline-directed therapy. Very intriguing inclusion criteria related to hospitalizations. Dr. Bimaraj highlighted the concept and observations that patients that are frequently in and out of the hospital, that's a red flag for us in terms of projected survival. Certainly those patients coming up at 3 hospitalizations within the past 12 months have a projected survival as a whole overall cohort of around 50%, or mortality as high as 50% within the following years. You can get into INTERMACS with 1 heart failure hospitalization, in and of itself a red flag, but combined with compromised functional capacity, 6-minute walk test distance less than 300 meters, and this is a reoccurring number in terms of registry, roadmap, and is being used because it's been demonstrated that those patients that walk less, that's roughly less than 980 feet, it correlates with their functional testing as measured by cardiopulmonary tests, and it's a prognosticator, as well as biomarkers, serum sodium, and emergency room visits. So you can get into MEDAMACS with advanced heart failure features in keeping with this this inclusion criteria. I think it's also important to recognize that the Seattle heart failure score is being used more and more, even in those patients with advanced heart failure. And I'll show you the details of the Seattle heart failure score. It certainly was used in MEDAMACS and used in roadmap. And the interest is in how this score, which compromises several important prognostic factors, it takes them all collectively, how this translates into freedom from transplant, mechanical support, urgent, or death. And so you can go online. This is really derived by Wayne Levy at the University of Washington from the PRAISE trial. It has been the most robust model in terms of prospective validation, now and coming up close to 10,000 patients, where one can put in age, important patient-specific characteristics related to gender, ischemic or non-ischemic etiology, background medical therapy, the dosages, and important lab data, which has been proven to be prognostic. And you can get a score that gives you their 1, 2-year, 5-year survival. Now, it has been reported, and this is in keeping with our observations as well, that in the most advanced heart failure patients, this score underestimates the risk, or it overestimates survival. With that caveat, when you look at more contemporary data, in those ambulatory patients, it holds up pretty well. This is by Levy and colleagues from Columbia and Michigan. And survival free of urgent LVAD, transplant, or death certainly was worse for those that had the higher score, above 2.5 being concerning. We've looked at the Seattle heart failure model in our patient population. We represented its use considering the full breadth of our evaluations, roughly 2/3 inpatient, 1/3 outpatient. But when we just tease out those with ambulatory heart failure referred to our institution, about 90. The area under the curve in terms of its accuracy to predict, if you will, death, urgent LVAD need, or transplant is very good with an AUC of 0.82. So I think this, for us, is very reassuring as the go-to model to use. In MEDAMACS, those patients with a higher Seattle heart failure score, a worse projected survival, there was a correlation or association with an INTERMACS profile reflective of greater severity of disease, as highlighted here. From MEDAMACS and those with an event compared to no event, again, no event meaning didn't die, didn't need an urgent LVAD, or didn't need transplant. As listed here upon these baseline characteristics, an advanced heart failure patient profile, there are no significant differences, interestingly, including hospitalizations. But those patients that had events, as one would have hypothesized, those patients with more severe breathlessness, at rest or minimal exertion, these patients are the ones that were having the events, and those with a higher Seattle heart failure score. And so this is event-free survival derived from MEDAMACS. And at 12 months, just 56% of the population were free of death, need for urgent LVAD, or transplant. And when you break up the MEDAMACS pilot study, and this is provided to me courtesy of Dr. Jeff Truderberg, a colleague and friend from Pittsburgh, those with more severe ambulatory advanced heart failure, shortness of breath at rest, their event-free survival was just 28%. And INTERMACS 5 compared to others, 6 and 7, 58%. And when you look at it in terms of the Seattle heart failure model, those with a score, and remember this is a high, greater than 2.5, dismal, right, event-free survival at 1 year, just 15%. So MEDAMACS, this has not been published. I'm going to show you the only published report by Garrick Stewart and Lynn Stevenson in a minute. But the preliminary observations are that not negligible risk in these patients with these advanced heart failure features. 44% experiencing an event at 12 months, nearly half being death. So I think that is telling. MEDAMACS registry data observational studies like ROADMAP are shedding light on quality of life. Again, patient-reported perception of their overall health status. In these ambulatory advanced heart failure patients, a quality of life visual analog scale score of 52, which is similar, a little better than what we see from the destination therapy trials of around 40. But very intriguing data when the MEDAMACS investigators stratified 6-month survival on those patients with, at the time of enrollment, with a visual analog scale score less than 50, again, reporting feeling overall worse, their 6-month survival was worth. I think patients have a lot to tell us that influences their prognosis, above and beyond our assessment of in a semi-quantitative way using New York Heart Class. And I'll show you what ROADMAP has to say in this regard. This is from Kathleen Grady at Northwestern, and very intriguing data in that even in those patients with not as much breathlessness, less severe heart failure, INTERMACS 4 through 7, their pre-implant, based on INTERMACS, pre-implant visual analog scale scores are under 40. They're still very, very, very poor. Very importantly, post-implant at 3, 6, and 6 months and 1 year, their post-implant quality of life per patient perception improves significantly. So it's certainly reassuring that you derive a survival quality of life improvement in the sickest. Certainly surrogates, if you will, that the same holds true for less sick patients. But there has not been a randomized trial to test this. So with these projected benefits, much enthusiasm. This is our reality based on INTERMACS 5, 2-year data derived from 2 years, published 2 years back. The percent freedom for patients receiving continuous flow pumps, freedom from infection, bleeding, device malfunction, stroke, or death at 1 year, it's just in and around 30%. So you flip it, the vast majority of patients may experience one or more of these composite endpoints in terms of freedom from event-free survival, if you will, with the understanding that not all these adverse events are created equal. We're coupling composite of infection, bleeding, device malfunction. But adverse events are certainly real. This was sent out by the FDA. I received a nice email from our IRB in the context of serious adverse events in the context of recent reports. For the HEARTMATE 2 pump thrombosis, Randall Starling from the Cleveland Clinic and 2 other institutions reported a pump thrombosis at 30 days as high as 8.4%. Based on INTERMACS, it's around 6 to 7%. Our institutional experience has been on the order of around 5%. And with the HVAD incorporating the results from the endurance trial, 28% at 2-year prevalence of stroke, which was certainly greater than that compared to the HEARTMATE 2. But both pumps, again, this is the only one approved for destination therapy. This is currently under evaluation by the FDA. But concerns about adverse events, and while this data, certainly the pump thrombosis data, is older data, we want to take this in consideration. So where are we today, and what does roadmap show us? Based on INTERMACS, 80% of all pumps are placed in those that are the sickest. And that was a cohort that we noted the benefits exceeding the risk. INTERMACS, critical cardiogenic shock or inotrope dependent. Only 20% of patients are receiving LVADs with INTERMACS profile 4 through 6. For the reasons I mentioned, really a lack of randomized data, some concern about adverse events, albeit with the backdrop of increased utilization and enthusiasm for device support. And so ROADMAP was the first observational study in non-inotrope dependence patients with INTERMACS 4 through 7. Revive It was an NIH-based collaboration between industry and clinicians to randomize, as an attempt, LVAD versus optimal medical management in INTERMACS 7 patients. This dates several years back. We were really taking a leap of faith, going from the most sick to the least sick to try to understand. This was closed because of loss of equipoise in the context of concerns about adverse events, and most importantly, failure to recruit. We as a group of 20 sites randomized 1 patient to medical management. And so ROADMAP positions us nicely to go from that transition of the most sick perhaps to the less sick with clearer data. And so I had the opportunity, as kindly mentioned by Dr. Vimmerhuis, to represent the group at large. This is available online, and we're excited that it is highlighted as the original investigation with CME credit. And our group did well in terms of enrollment, but what this slide shows us among the 41 sites, appreciate the heterogeneity in the use of optimal medical management, red bars, versus green, LVAD. In a cohort of patients, I'm going to give you the specific inclusion criteria, but in a cohort of patients that met the destination therapy FDA indication for VAD. So they're being referred to advanced heart failure centers. They meet the FDA approval. The observational design was to offer LVAD to all patients, with the understanding that there'll be institutional heterogeneity in terms of pursuing medical management from a patient and/or physician perspective, and you really see that here. And so it was prospective, again, non-randomized but controlled, observational. It importantly allowed characterization of heart failure treatment strategies, pursuing medical management versus LVAD in different delivery systems based upon the differences in the 41 participating centers. The primary objective was to evaluate and compare the effectiveness of LVAD versus optimal medical management, those that met the indication for DT, that were ambulatory, non-inotrope dependent, New York Heart Class 3B or 4. CMS mandates, at least in terms of coverage, New York Heart Class 4 symptomatology. And these patients often, as we know clinically, can fluctuate from shortness of breath with minimal exertion, bathing, showering, to shortness of breath at rest or orthopnea. So there's some nuance there I like to highlight. But to get into the trial, not only did you have to meet the FDA-approved DT indication label, you had to have a surrogate of poor functional capacity. We use 6-minute walk distance, less than 300 meters, and at least 1 heart failure hospitalization, given that that's a red flag for severity. And key exclusion factors really trying to tease out those that were more sick and those that had recent work done that may alter the natural progression in a favorable way of their heart failure, exclude the patients with recent revascularization or CRT. By design, primary endpoint composite of survival with improvement in 6-minute walk distance of at least 75 meters. This was a cutoff based upon a post-approval study data available. at 12 months. Very important secondary endpoints in terms of survival, health-related quality of life, depression, which is an often overlap with clinical heart failure, and metrics related to functional status, and importantly, adverse events. I reviewed the EQ5D. This, for us as cardiologists, perhaps less familiarity. The PHQ-9 as a screening tool for severity of depression has been used by primary care physicians, and this has been validated against the DSM-4 criteria for depression. Specifically, those patients with a score greater than 10 have moderate to severe severity of depression. Standard statistics and independent validation with use of a biostatistician. So here's the demographics between those that received ongoing medical therapy, 103 patients, compared to those that received LVAD therapy, 97. Median age around 65, and again, that mirrors what we saw in Rematch, that mirrors the median age in the HEARTMATE 2 destination therapy trial. Based on this slide, no differences in gender, underlying ischemic, and some background medical therapy, with the exception that patients in the LVAD group, a lower percentage were on background beta blockers. There are 5 important differences comparing the LVAD cohort compared to the OMM cohort that define the LVAD patients as being sicker. Namely, a greater percentage had shortness of breath at rest, class 4. A greater percentage were INTERMACS 4. There was a trend towards a more compromised or lower 6-minute walk distance. These patients were telling us that they felt worse by the visual analog score, and they had a greater severity of depression, in addition to a trend towards lower predicted 1-year survival using the Seattle heart failure model. In terms of patient perception, those that agree to LVAD or chose an LVAD, they're agreeing with the physicians recommended it, they at baseline, those that received an LVAD is highlighted in this cohort, 79% were not, or only slightly satisfied with their baseline quality of life. That's in comparison to those in the OMM group where roughly half were moderate to extremely satisfied. So less sick features and patients telling us that they're pretty satisfied. This is in the JACC publication. In addition to being satisfied with quality of life, very interesting data, those on optimal medical management, the vast majority felt that based on continued medicines that they would be alive more than a year, in contrast to roughly half feeling like they were going to die over the next several months. I think the patient's vote counts, and what they're telling us is key. These are the top 3 reasons why patients agreed to LVAD or chose LVAD pre-implant. Chance to live longer, improve quality of life, and return to activities that they enjoy. In the optimal medical management group, not wanting device surgery, not wanting to depend on the machine, and not feeling sick enough. The 4th, in terms of the percentages, concerned about too many complications in about 21%. The physician reasons on why one may have FDA indication, meet indication criteria, but may want to pursue OMM in a non-inotrope dependent population, perhaps not a good surgical candidate for a variety of reasons, or the patient telling us they don't feel sick enough. So here's the flow diagram that really defines the trial, and I want to highlight that the withdrawal rate in the OMM group was 3-fold that in the LVAD group, and that 18 patients ended up receiving a delayed LVAD, in part for worsening heart failure. But by design, this was counted as a failure. And so when you look at the primary endpoint, alive at 12 months on original therapy with increase in 6-minute walk distance, a greater percentage of LVAD patients met this compared to those in the OMM group. The primary driver for meeting this composite endpoint was the use, roughly 18 patients, 22%, the use of delayed LVAD in those that were originally being treated with optimal medical management. There is no difference in survival or death at 1 year. So here is event-free survival. 80% that received an LVAD were alive and free from urgent transplant. In contrast to those with receiving optimal medical management, alive and free from urgent transplant or urgent LVAD, 64%. Please note this is the lowest perioperative mortality to date, just 1%. Those that received an LVAD coming in from home, if you will, had a 30-day mortality that was equivalent to that of not going through surgery. But certainly, we're concerned about changes that may take place after the 30-day period. So that was significant. I've mentioned this in terms of the drivers for the trial. Intent to treat survival, when you have a backup LVAD, if patients are doing worse, or if a patient changes their mind, survival, intent to treat at 1 year was the same for both groups. And when you take a step back and ask, well, is there a penalty to wait for patients to get worse and become perhaps inotrope dependent or INTERMACS 2? That is going to be the focus of the 2-year follow-up for the roadmap trial. The experience we have based on the 1-year data is that those patients where they had received the delayed LVAD, albumin decrease, 6-minute walk distance dramatically decreased. They had a higher severity of depression, a worse Seattle heart failure projected 1-year survival, and a significant percentage of these patients were then classified as INTERMACS 2 or 3. They're getting worse. Now, the details of benefits and risks are to come with the full 2-year analysis. These pumps do a tremendous job at creating heart failure remission. They reduce left ventricular end diastolic pressure, they reduce left atrial pressure, the breathlessness that is the cardinal symptom that defines heart failure is improved in the vast majority of patients on LVAD support. Whereas, as perhaps one would hypothesize, those that are receiving ongoing medical management, really the majority remain class 3 or class 4 at 12 months as highlighted here. In terms of those patients that were alive at 12 months with available paired tests to compare 6-minute walk distance, those that received an LVAD had a significant increase in their 6-minute walk distance compared to a not significant increase in the OMM group. Similarly, those patients on LVAD support had a significantly greater increase in their overall report of how they're doing based on the visual analog scale. And it was significantly greater compared to the change, greater than the optimal medical management group. And patients that received an LVAD at 12 months that were alive transitioned from moderate to severe to significantly less depression with a decrement in the PQH9 score of negative 4.7, whereas those in the OMM group, albeit had less severity depression, didn't change much at 12 months. So we defined a secondary composite post-hoc endpoint of alive at 12 months with improvement in New York Heart Class, quality of life using the cutoff as highlighted here, and depression. And patients on LVAD support, the green bars significantly met this secondary endpoint compared to those in the OMM group. Now, adverse events we need to talk about. They were common in this trial, and I've listed here the prevalence and incidence of adverse events in the LVAD group and the OMM group, and for your reference, the destination therapy trial. Adverse events were more common in the LVAD group compared to the OMM group. Bleeding was the most common event, with GI bleeding accounting for 2/3 of all bleeding events. Bleeding in general accounted for 2/3 of all adverse events. A prevalence of GI bleeding as high as 31%. Driveline infection, in terms of incidence, lower than more recent landmark trial at 9.6% at 1 year. Pump thrombosis in this cohort of patients within 90 days, in contrast to the FDA warning report, 1.1% versus what was reported on 30 days, a little over 8%. So lower, with need for replacement at 4.3%. Stroke risk, consistent with what we've observed in other trials. Hospitalizations were frequent, and we know this, right? The fellows taking care of these patients in the middle of the night. We have a low threshold to admit patients, right? Whether it's a change in symptoms, alarm troubleshooting, anticoagulation management. But hospitalizations was frequent in both groups in terms of the prevalence, a little higher actually in the LVAD group. Worsening heart failure, on the other hand, in those treated with medicines was greater compared to what the purpose of the pump is to ameliorate the heart failure syndrome. So overall, the composite event rate was higher in LVAD patients compared to the OMM group. So how do we put all this together? And this forest plot nicely illustrates the projected benefits, or the benefits observed actually, in terms of alive and improvement in 6-minute walk distance in LVADs compared to OMM patients. Survival, this is event-free survival. Intent to treat survival is neutral, with important improvements in these quality of life metrics, with the understanding that adverse events as defined. We didn't weight adverse event of infection or exit site or management of anticoagulation. We didn't do a weighting to try to perhaps provide better clarity, but we created a composite And as we defined it, adverse events were more common in the LVAD group. So this is a central illustration, and the point of roadmap is not to say you should put in LVADs in all patients that are non-inotrope dependent that meet the FDA indication criteria, but I think those patients that have these advanced heart failure signs are telling us they feel bad, you should have a conversation about the projected benefits and risks of pursuing medicines versus LVAD therapy. Doug Horstmanoff was kind enough to allow me to show this slide. It's going to be presented at AHA. When we stratified ROMAX in terms of INTERMACS profile, event-free survival is lower in those that are sicker, but non-inotrope dependent, INTERMACS 4, shortness of breath at rest, than in those with INTERMACS 5 to 7. So here's the event-free survival in the OMM group. And when we do the same force plot evaluation in terms of projected benefits and risks, those patients that are INTERMACS 4, much more pronounced benefits and perhaps less risk, certainly as it relates to hospitalizations, where those patients that are treated with optimal medical management that have rest, shortness of breath, they have more frequent hospitalizations. But the adverse event profile is still in favor of OMM. So let's take a step back, and what have we learned from these observational studies, cross-sectional MEDAMACS and ROADMAP. In a cohort of patients a little older, depressed EF, less than 25%, high-grade symptoms, what I would qualify as high-grade symptoms of shortness of breath, surrogates of patients not telling us they're not doing well, with a Seattle heart failure score that's higher than low, medium to high. Event-free survival in these patients is not negligible. Very intriguing data available online, will be published in the Journal of Heart and Lung Transplant. 50% of patients in MEDAMACS registry would want, or at least would want to consider LVAD therapy based on how they're feeling. And these are the patients that are at lower risk in terms of perioperative risk. Very intriguing. Those patients with a INTERMACS of 4 compared to 5, 6, and 7, there's greater enthusiasm for consideration for LVAD. Again, whole different cohort of patients from 10 different centers that were not participating in ROADMAP. And so we have what I think is a very nice project, part of collaboration between our Baylor College of Medicine ethicist colleagues, statisticians. It really spans the Texas Medical Center, where we've completed a decision aid to help inform patients of projected benefits and risks of medicines versus device versus palliative care. We are actually now in the derivation and the validation phase, us, Texas Heart, Cleveland Clinic, Ochsner, I don't know if Jenny and Courtney Bruce are here. Ochsner's all in addition to Baptist Integris and Aurora Health. And our colleagues, really strategic in terms of our contribution to ROADMAP, put forth the editorial for the ROADMAP of JACC publication. And really this needs to be we need to focus in on what this means for an individual patient. And so in our decision aid, we're very clear about projected benefits and risks along the lines of what I mentioned. We use visual cues, cleverly defined, to help quantitate or qualify perioperative risk and long-term risk. I think ROADMAP trial and future trials will guide us to better understand the projected risks in this patient population and how these risks may change with improvement in device technology. I think it's very enlightening using registry data to understand patient perception about concerns related to perhaps fear, stroke, pump durability, infection, where if you look at what we're seeing from ROADMAP, it's GI bleeding, maybe some consideration for stroke and rehospitalizations. So it allows us to be clear with our patients on the conversations to have. There are a variety of reasons why patients may decline in LVAD, and it's perceptions about really having good information, perceptions negative related to that these patients won't be mobile, some consideration that it's experimental. And so we could use data like this to help guide us in these conversations to be clear to them to help as a team make a decision. Very, very important to include the caregiver in this regard. They're the ones that support the patients, not only early, but for the remainder of that patient's life. And we test these patients in terms of what we're teaching them, and the education process is far above and beyond just the decision aid. We're actually testing to make sure that they understand. So I think that's key. So let's talk about in the last 3 to 5 minutes, new horizons. Now, the HEARTMATE 3, as part of the Momentum trial, is based on full magnetic levitation technology, where blood from the left ventricle enters the pump. Because of improved gaps in terms of sizing, blood can can flow around through the pump to get to the ascending aorta in a way where there's much less shear stress, less interaction with the contact surface, with the hope that this minimizes adverse events. Another very intriguing feature of this pump is that its speed will decrease in increments of 15 seconds to where you get washing out and less stasis through the pump, with the idea that maybe adverse events, thromboembolic, will be less. This will be the largest trial to date, projected to be over 1,000 patients in patients with advanced heart failure. Primary aim is to assess safety and efficacy. Already 279 patients enrolled. Really, in the basis of the team's efforts at large, we're doing well. We want to position ourselves to have a good experience with this pump in the context of what we're seeing based on the European experience. So Dr. Ivan Antuka and colleagues at Thoratec were kind enough to allow me to share this. This was presented most recently, a few weeks past, at HFSA, the preliminary experience with the HEARTMATE 3 based on 50 patients, European experience. This was in the context of bridge to transplant or destination therapy. Fairly high incidence or use of LVAD in INTERMACS 4 patients, but predominantly sick patients with 60% INTERMACS 2 or 3. And the performance goal was based on the contemporary HEARTMATE 2 cohort, but 6-month survival, 92%, compared to 88% HEARTMATE 2. And that's very, very reassuring. And as expected, metrics related to functional capacity and quality of life look very favorable with the HEARTMATE 3. And the most enthusiastic data in my mind to share, albeit with the caveat this is under investigation of a large trial here in the United States. GI bleeding, and this is at 180 days, 0 to 180 days prevalence, 8%, stroke, 12%, consistent with contemporary findings. But look at this, pump malfunction, pump thrombosis, hemolysis, 0%. So I think as the field evolves in terms of technology to minimize adverse events, we get better at patient selection. I think that benefit risk assessment will change. And here's the inclusion, and really this trial is also unique in that we don't have to commit to destination therapy as a label or bridge to transplant, but really extended support for patients, depressed EF, high-grade symptoms. We're participating in the Reliant Heart. Really stems from who put our program in our hospital on the map, Dr. DeBakey's pioneering development of the first continuous flow pump. This was a heart transplant patient here. He worked with shuttle technology. This is axial flow. This is a DeBakey Noon Micromed. It's become the Reliant Heart. It offers the two advantages: direct flow measurement to help us troubleshoot, and technology to help with home monitoring. So we're enrolling in this multi-center trial, and in the context of the HEARTMATE 3, they've approached the FDA to widen that indication. So to conclude, I just want to share some of our dashboards related to our destination therapy LVAD program, our VAD program. I started in 2007, and again, as I mentioned, we were doing between 12, 18 LVADs. We are doing now about in excess of 50 per year. Our INTERMACS profile, we still see a fair amount of INTERMACS 1, and that's not by design. We care for the patients we see. But roughly 80% are INTERMACS 1 through 3. Despite that, a higher percentage of INTERMACS 1, specifically our destination therapy cohort, our 1-year survival, 2-year survival mirrors that of INTERMACS in and around 75% at 1 year. We have an outpatient census of a little over 120 patients that we're caring for, and long-term survivals over 3 years, over 30 patients. So this has been really a robust experience for us, and these patients, by metrics of 6-minute walk compared to pre-implant, are doing well long-term. And so to conclude, I think these patients that are non-inotrope dependent, high-grade symptoms, in and out of the hospital, poor quality of life from their perception, these are the types of patients we want to evaluate early, not to necessarily say we're going to go down the LVAD route or transplant route, but really tailor the workup to them in terms of consideration for intervention in terms of LVAD or transplant. Survival, destination therapy, around 75 to 80%. This strategy is in excess of 40% at our hospital, as I mentioned, roughly between 65 and 75%. While adverse event burden may be on the slight decrease related to infection, continues to be a challenge. I think Roadmap really highlights the benefit and risk in a select patient population to where these patients really can derive a benefit when carefully selected. I think the take-home message is, in these advanced heart failure patients, early referral to allow us to weigh in. Now I'm standing here, with having the privilege to report this. The team at large that makes this possible Certainly you all know us as the dedicated heart failure team. I still consider Dr. Noon part of our team in terms of his leadership and his mentoring, and even though he's not actively doing surgery, the principles he's put forth in terms of high quality care and discussion have really have helped us continue to build upon our program. Dr. Loby was instrumental in terms of participation in roadmap. Dr. Bruckner has taken the lead and is our surgical director, and our program in terms of the collaboration between cardiology, surgery, full breadth of coordinator needs to make our trialists work real, the clinical research team, and of course the mid-levels, Lauren and Danelle and Brittany, that take care of these patients in the hospital along with the team at large. In addition, the perfusion team, quality coordinators, the list is big. But a sincere thank you to the team at large for allowing me to be part of it. Happy to take any questions.
Jerry, that was a great talk, and you have a great team over here. What does this cost? Let's say, let me be more specific. What does it cost Medicare for the implantation and the care of one patient in the first year?
Yeah, so very good question, and I have my colleagues right behind you that have all the up-to-date data. But you know, for the cost of the device, can range in around $50,000. In terms of, I know our net profit margin for an individual patient, but it can cost up to $150,000 to get these patients through. 1 year data I don't have at the top of my head, but in terms of cost effectiveness in a Medicare patient population, if you take into consideration certainly those that are sicker and use of resources in terms of rehospitalizations, and what's hard to quantitate is quality of life improvement and how you weigh that in. The thought is that it's cost effective for select patients, but I'm happy to provide you clearer 1 year cost related to device support in a Medicare patient with use of my colleagues.
I have some difficulty with the depression and the walking business with that data.
Yes.
And my difficulty is that people who are depressed don't walk. What I would like to propose is that these people really don't have clinically significant depression in the psychiatric sense. They're more sad. Their sadness disappears when they get better, and so they walk better. If they really get into a depression, a psychiatric depression, whose symptoms really sort of overlie, except for the shortness of breath, overlie the symptoms of congestive failure, they're not going to walk very well. And so the question is, how does the team respond to that?
Yeah, so I appreciate your point. I think it can be a challenge to delineate true underlying depression that may need pharmacologic therapy for depression, as opposed to this smoldering heart failure and how it influences their perception and/or sadness. But when we use this metric, the PHQ-9, that has been correlated with the rigors of the DSM-4 for diagnostic for depression, whether it's overlap with heart failure and its influence, I think the message is clear, and we see it clinically all the time. If you can treat the heart failure, this one could call it perception of depression. I would say depression, at least based on diagnostic criteria, depression gets better. It can be challenging in an advanced heart failure patient with medicines. If you're not going down LVAD or transplant, it can be hard to treat depression. For the reasons you mentioned, overlap between depression being exacerbated by heart failure and how it influences patients' perception of well-being, and how depression can then make you less likely to walk, more deconditioning, and maybe perhaps some challenges with compliance with medication. So I see it as an overlap. Me as a heart failure specialist, I try to treat the heart failure aggressively, and I think what this is telling us, at least in terms of an outpatient population, that depression is not uncommon, and if you treat heart failure, depression surrogates can improve. But this needs to be done in close collaboration with psychiatry and appropriate screening in terms of treating depression, concomitantly with heart failure management, to ensure that suicidal ideations and progression to a worsening state or high severity depression is taken care of. So a long-winded answer of me saying I agree with you. I think it can be a challenge. I think there's an overlap, but the signal in my mind is clear. If you can treat the heart failure, you can improve these surrogates of depression. Mr. Winters.
Jerry, what happens from your perspective, from the physician's perspective, has this complicated your lives? A lot more. Has this complicated your lives in taking care of these patients? What happens to their primary care physician? Do you become their primary care physician? You take care of all of their problems now?
So, excellent question, and the answer is yes. The good news is we've become the primary care physician for post-heart transplant patients for the last decade. So I say that in that we went into internal medicine, we went into cardiology, then we became heart failure specialists, and we've continued to practice that. But you bring up a good point. As technology improves, and we're doing this and more, and for the first time over the last few years, we're doing as a community across the country more LVADs than we are heart transplants. And as the risk-benefit closes in terms of greater benefit versus risk for more patients and availability, you'll see more patients out in the community where they live. So it's hard for us as heart failure internal medicine champions to take care of the full breadth of disease because there is still the perception of being uncomfortable with taking care of an LVAD patient. But as the fellows can attest to, when they come in, they can have comorbidities related to COPD, they need diabetes management, they have, especially in an older patient population, they need concomitant care. So how we've approached it is twofold. We work with a dedicated group of consultants that have a general understanding about LVAD here at our hospital. And what we've been doing more aggressively is creating a shared care model with referring physicians. One of the first slides I showed was our outreach efforts that extend as far as West Texas and El Paso to the south. And so we educate the referring community to have some basic understanding of LVAD. And I think for those patients that have the most adverse events, they're still best served at the primary implant center. But I think it's very forgiving in terms of some of the basics, especially when managing the comorbidities, with the understanding that it's not the heart failure perhaps or an LVAD complication accounting for that patient's symptom or problem at that time. But that is the challenge moving forward. It's getting everybody on page for the primary care sector, cardiology in general, heart failure specialists, with algorithms that qualify as best practices care and screening to ensure that these patients' well-being is put in perspective, the full breadth of what you mentioned. Dr. Noon.
I just want to say that it's a wonderful presentation that you made, and how important it is to have good patient selection to get good results. Back in 1998, we did the first in the world implant of a continuous flow pump, which was a DeBakey Noon axial flow pump, which we did in Germany. And at that time, there was grave concern about how patients would do with long-term support with continuous blood flow and whether it would really be something that we could utilize. And the studies that you've shown today, every one of those pumps is a continuous flow pump. The only pulsatile pump that's on the market today now is a total artificial heart. So I think that we've shown that you can really get by with just continuous blood flow.
Yeah, I agree, a testament to you and your pioneering work. Well, I appreciate everybody's attention. I'm happy to field any other questions.